There's one question about people needing tincture of opium or paregoric, and that's been very helpful. It goes way back in the literature. We also heard about Periactin and Zofran from, I think, Dr. Thomas, and those are broad serotonin antagonists. And for me, it's been helpful to use Periactin or cyproheptadine syrup, because you can, if you use the syrup, it goes right through the stomach. Liquid emptying is very rapid, so you get the full effect, if any. But it also tells you if there's a serotonin-mediated part of your diarrhea. And I think that's important. And before you do an initially large workup for mid-gut, is one of the things you can use for a patient that would help them in some diarrheas, is just to test to see if those work. They're very available. Zofran is more recently described in the New England Journal of Medicine as a letter, and it's I think it's a receptor 3, serotonin 3 antagonist. But Periactin goes back 80 years almost. It's been around that long, and before we had octreotide, the use of a H2 blocker plus the Periactin was used broadly to help control diarrhea and carcinoid before octreotide came about. So we'll just start going on these questions here. Yes, please.
Can you allow me to answer this question?
Which one? Oh, of course, yeah. Can you go ahead and read it, Mia. And
all right. Okay, I need to have the disclaimer. You know I'm not a doctor, right? I just work in a lab, so. I recently changed oncologists. My blood was always taken the normal way before. The new oncologist took, new oncologist. Okay, so basically they're asking a question about the collection of the blood, and essentially does it have to be collected and can it affect the result? So yes, it needs to be collected correctly, and otherwise you will not get a proper result. So on this specific one, let's talk about it offline. Okay.
Okay. Pardon? So, but this may be along the lines, is ISI the only place to get the blood work done? Or is there another place? Cambridge offers, and one of the things that's important about the lab is that it's a broad performance of the lab test. Up until many years, probably 8 or 9 years ago, a couple of labs would do this test or that test. And I think you're best served in the setting of the Inner Science Institute because they do the broad spectrum. They're very careful about blood collection. They'll kick the sample back. They'll provide the tubes. Cambridge is kind of a new kid on the block, and a lot of the folks east, like New York, will send to Cambridge. And Cambridge is okay as long as you keep getting those tests there, but reproducibility is critical in terms of something like neurokinin A, because you'll get a 500 on a sample and you have to redo it to see. I mean, that sends people into a tizzy, and it's very understandable because they see, oh my God, this is what it means in the literature. Is this what's happening to me? So I think reproducibility, it's been remarkable for me over the month, every 4 to 6 to 12 month collections, the reproducibility of the samples and the steadiness of a tumor. You can read just by looking at the profiles. You can pretty much predict what the CT scan is going to show. So. But I don't know of any other lab except Cambridge outside of ISI that may do multiple testing. I'm sorry if there is, and somebody can say, but I don't know. It says, please repeat the names of Creon 12, kosher pill, and papaya. Okay, so the Creon 12, Creon 24, Viocase, and Dr. Metz, I don't know if he's in the audience. He's a gastroenterologist who's been in the field of neuroendocrine work for many years. If he's here, he'll be speaking tomorrow. And Dr. Warner's here, I hope, still, so could answer things on the GI that I'm not very capable of. But Zenpep, the VA uses a lot of Zenpep, Creon 12. Those are animal extracted enzymes. The kosher one is called Digest Gold, and you can get it on the website. I think GNC carries it. It's made from vegetables, and it has a kosher seal on it. You can use it. I have a few patients on the kosher, and the papaya tablets are the cheapest. And the trick on papaya is you got to take more, 3 to 5, sometimes 6, because they're all one concentration. And so if you take not enough, then you won't. It may not work. People like to chew them while they're eating, so apparently that offers an advantage too. They tell me. So it's
black raspberry.
So I don't know, Gene. Dr. Woldering's here about the black raspberry powder. That's I mentioned that. Can you comment on the raspberry powder, Dr. Gene?
Who would have their liver taken out and oxygen and we tested the lab and have found anti-infective effects. We offer those we don't recommend it as an anti-tumoral agent. Yeah, also recommended we do recommend anti-diarrhea. If you've got diarrhea that sounds like try black raspberry, talk to Lucy. Lucy Wiley is an advocate. She does stuff like a black raspberry. Woman raspberry, I hear you.
Yeah. Oh, God. Sorry. You got off, Dr. Gene. Huh? You want to? I told you to come up here, by gosh. Huh? We better move, and he maybe can slide up here in a minute. We'll make a chair for him. Will use of chemotherapy treatments, including chemoembolization, prevent a patient from receiving PRRNT or peptide receptor radiotherapy or radionuclide therapy? You'll see it as PRRT or PRRNT. Dr. Berglund, Dr. Wolin, you want to try that one? Since I'm very biased, I have to be careful.
The short answer is no. It's been used before and after. It needs to be used with care. You don't want to use it within a couple of months of treatment. You don't want to use such a treatment within approximately 3 months of having PRRT treatment, but there are reports where it can be successfully done before and after. It has to be done with caution. There's some patients who have extensive liver disease that have a risk of developing liver failure if you have those kind of treatments in PRRT in close proximity. So it really has to be determined on an individual basis, but it doesn't absolutely rule out PRRT if somebody has had liver-directed therapy.
I would agree.
Go ahead. Just another comment, Dr. Bergson?
Yeah, no, I don't have much else to add other than separate from the chemotherapy issue. I think what I don't think has been thoroughly studied is radioembolization of the liver and PRT and sort of how those link up with each other and safety and what have you. But I would agree with Dr. Wolin that these things have been done in the same patient, but more needs to be learned about the precise sequence and the limits to using these various agents in each patient.
That's a keen statement, because when the PRRT started coming out in 1996 from Europe, there were some studies, at least one study out of Basel, Switzerland, that suggested the prior use of chemotherapy drugs, and I want to say strep was one of them, maybe made the patient more prone to the radiation effects and even causing some marrow toxicity. But that has not been looked at all, and it's going to be very important to know how you intersperse. I think you mentioned there's one with interferon and PRRNT. There's another one from West Australia that uses everolimus. I don't know what that study showed. I think right after the PRRT. It makes a lot of sense, but we really need to be very careful with it, because we just don't know what it can do to the marrow, in terms of sensitizing the marrow for more damage. Ed, did you want to comment on that?
No, I agree. We have to await the studies. 5-FU is another drug that's been used, or Xeloda, in combination with PRT. All of these things are very early in development, and we have to await toxicity data.
Yeah, you got to start.
These things are all new in development. We have to await toxicity data, and people who are having PRT need to have other therapies considered closely with their oncology team.
Yeah. Is there any study that compares lanreotide with octreotide toe-to-toe? Most of that was done in Europe with acromegaly. Dr. Berglund referenced acromegaly. It's a tumor from the pituitary that causes excess growth after bones are closed. And Andre the Giant had acromegaly, but that was in remission. But lanreotide came out first for that, and octreotide then was used, and they've gone side by side with it. In general, at least with those studies toe-to-toe with acromegaly, it generally takes a little bit more lanreotide to do the same thing that octreotide does. So that has to do with the microgram to microgram equivalent. But for the most part, you turn them upside down, they look the same. They differ by one amino acid, but the binding unit lysine is right there in the same position in both of the peptides. If the structure is identical except for an amino acid transposition. And so for the most part, they're in the same class drug. Here's one from Colorado. I don't know this for sure. Are there any studies on marijuana effects on network? I think, who goes to the smoke shop in Denver? Just raise your hand, that's all. I don't know, I passed it on the way, So, okay, this is kind of an interesting one, and Dr. Thomas, is there any correlation between episodes of flushing to episodes of diarrhea? Can you tell in terms of your work with the Telotristat?
From a practical standpoint, most patients, when they have diarrhea, they often have flushing with it, but I have met some patients where they just manifest with flushing alone and no diarrhea symptoms in and of itself. And so that is possible to have them. And again, it's questionable of whether serotonin drives the flushing episode in the first place. Maybe it's the histamine, maybe it's the bradykinin, substance P. There are other factors that are being secreted as well and probably driving that flushing episode.
Yeah. If I could just make one comment. As we were talking about octreotide and even lanreotide, but mostly octreotide, and they talked about the symptom control. Actually, flushing was one of the most improved in the original studies that went to the FDA for that got the approval for the FDA. And one little Wrigley fun fact: they had 171 patients from both Europe and the United States. And there were 78 physicians feeding in the information to Central Sandoz at the time. And based on those 171 patients, 88 carcinoids and the rest neuroendocrine tumors that were mentioned, the FDA approved this drug for the symptom control of carcinoid and even the rarer one of vipoma. It's just incredible. And it was the first drug, as far as I know, that was approved simultaneously in Europe in November of 1988, and in January of 1989, it was approved, FDA approved. They used the FDA indication in both Europe and the United States for it. And if you look at that, the results of anybody using octreotide to this day, those numbers still show, and they're still the same. And that is, if Dr. Coles is here, he should stand up, because his primary work with his 48 patients in 1986 nailed octreotide's symptom control to the ground. I mean, it's identical to what we see today. It hasn't changed since 1989 and in the sub-Q form. I need help on this one. Can you please expand on your experience with patients on Captem with midgut carcinoids, mets to the liver? Have you seen decrease in tumor size? Do tumors get killed? Do they come back? Dr. Berglund, you want to try that one first? Or Dr. Woolen? We got such a team of hitters.
Maybe we both can, because okay. I can say that the sense so far has been that that combination is more active in pancreatic neuroendocrine tumors than in other types of tumors like midgut. But I would just caution everybody that we're still early on in terms of really well-controlled studies to assess that. But the sense is that it's more active in pancreatic neuroendocrine tumors.
Yeah, I would completely agree that in pancreatic neuroendocrine tumors, there are several studies right now looking very promising. And as you heard from Dr. Bergsland earlier, a randomized trial is going on between temozolomide alone and temozolomide in combination with capecitabine to see the extra value of the capecitabine in pancreatic neuroendocrine tumors. In carcinoid tumors, there's one recent report that looked like it was really the best thing since sliced bread for all different kinds of neuroendocrine cancer, but it's a small report. The data has not been reproduced in other centers, and we really have to await a lot more data. There's also a intriguing report from Dr. Kulke at Dana-Farber using MGMT assays to predict response. This is an enzyme that, if it's high, prevents temozolomide from working. And it looks like there are high levels of that enzyme in carcinoid tumors in most cases, which would theoretically make it quite inactive in midgut carcinoid. So I think that I wouldn't say it's wrong to try, and I don't think it's wrong to do clinical trials with it, but it's not something that I would say I would count on right now.
Excellent. Okay. Along those lines, and I think this is, it's a broad answer, I'm sure, but an important question. What are typical times to drug resistance for the chemotherapeutic agents discussed? And obviously, typical, I guess, times to relapse or resistance. Is that too broad a question to answer?
Well, it's a pretty broad question, but you can say that statistical averages might be a year, plus or minus several months, but there are individuals who could respond for many, many years, and we've seen people on somatostatin analogs with cancer didn't progress for 10 years or more. In some lucky people, sometimes it can be 5 years. Sometimes with mTOR inhibitors, we have people on everolimus for over 5 years. I have people on pasiriotide for over 5 years, but those are not average. Those are people that are sort of outliers who are having an exceptionally good response.
Yeah.
So.
Okay. I would make a comment that I'm going to make tomorrow, and it seems to me that folks, in terms of the response about octreotide, I think having gone through the 10 years of subcutaneous octreotide, and then in 1989 seeing the long-acting repeatable come with Rubin paper and Lowell Anthony, and the opening up of the long-acting, it seems to me that there was less desensitization or downregulation with the sub-Q, and the only thing I can think about is that it kept a regular rhythm. It had a perfect kinetic of 30-minute plateau, 30-minute rise, 1 hour plateau, and 2 hour half-life, as Gene pointed up. And then the LAR continues to shower, and where I've seen most of the resistance is people that have no known tumor identified, and they've been given octreotide in the LAR form, and they keep escalating because their symptoms break through. And it's a phenomenon that's reproducible in folks that have symptoms. I'll talk to our experience with that, and even biochemistry, maybe even the symptoms and the biochemistry being plus minus elevated, and they cannot be shown objectively to have tumor, and yet they're put on because of symptoms, and they keep escalating their doses. And I think it's because there are fewer receptors on normal tissue, and that's where you get into this phenomena of downregulation. But they have reported it, of course, with tumors, people. But in that case, a lot of times it's progression that you're going up against when you use the octreotide in higher doses. Is telotrestat therapy only effective in patients with high serotonin levels?
So when we see folks with the neuroendocrine cancer patients, diarrhea associated with gastronoma, which causes a lot of acid production, that causes diarrhea. Telotrestat's not going to help you. VIPomas and somatostenomas, the diarrhea they get from that is completely different. The physiology is different. Whereas if you have an elevated serotonin level, that's what's driving the diarrhea, and I don't think there's a requirement that you have a certain level to be a part of the study. It seems that telotrestat will just suppress the serotonin level. And the only requirement you need to be a part of the study is just 4 bowel movements and above and on a chronic dose of somatostatin analog.
Another question, and this one I think is very important clinically, and I'd like to hear everybody's thoughts. Are night sweats a form of carcinoid syndrome? They vary from clamminess to excessive clamminess to excessive sweating. What is the treatment? And they're not menopause related. And I've had many patients define exactly what a menopausal feeling is versus one of these that probably is a carcinoid flush during the night. And I don't know if you've observed it. I believe nocturnal perspiration is a symptom of carcinoid. I call it complex. I think only when the heart is really damaged is it the true syndrome. But yes, I think that's my response is I think it is carcinoid complex. A lot of times it's warm or cool. It's not necessarily a warm feeling when it's a serotonin mediated. But Ed and Dr. Berglund, you want to? Can you comment on your experience?
I mean, I guess I would just say I don't know. It seems that it's been reported more often than not in women. Mm-hmm. And so in my practice anyway, and I think it can often be a real challenge in terms of separating it from essentially postmenopausal symptoms from, true carcinoid syndrome. Yeah. So, but I don't know.
And the fix is 100 micrograms sub-Q right before your night prayers, okay? And it works. It works. Trust me. If it is carcinoid, it works.
I've had.
Go ahead.
Yeah, classically, carcinoid flushing classically is so-called a dry flush with no associated sweating, and that's what you normally expect from a midgut carcinoids symptom. However, I've had patients complain exactly as Dr. O'Dorisio has said, with sweating, and this can happen in men, this can happen in women who have no reason to be menopausal, and it probably is a real phenomenon. It may be that it's mediated by some different things. For example, if you have histamine or something other than serotonin causing the flush, that it may, there's some things that may affect the sweat glands of the skin, whereas serotonin doesn't really affect the sweat glands. It only affects the dilation of blood vessels, making you get red. So I think that it's sort of a complex issue, and I agree that we have to always rule out menopause, but it certainly can be due to carcinoma.
You could try it, just try a shot and see. I mean, if it does, because it usually takes high levels of octreotide for menopausal symptoms. It can work. Octreotide can work, but you have to give very high doses to to help those symptoms. It's not indicated for menopausal symptoms, but it has been used for it. Go ahead.
I was just going to say, not on the carcinoid side, but on the hormone side, don't forget that's something else that you can check. You can get your hormone levels checked to see if you're perimenopausal, menopausal, or postmenopausal. These are just simple blood tests that are going to give you information about where you are in that cycle of life.
There was a question in the back. We can try it. Do you still have it?
I'm just curious, what was you were saying before? What was that?
100 micrograms sub-Q of octreotide. See, and then see if the symptoms continue during the night.
Well, I'd like to throw something out. I've had 11 liver embolizations. Crazy, but almost a clockwork, about 1 or 2 weeks after the embolizations, I would have my sweats.
So this person had 11 embolizations to the liver, and repeatedly 1 to 2 weeks later, you could make a case for release of. You could make that case. I think it's a good case, and that is interesting that it's correlated with the sweats, because that's the embolization. A lot of times, especially if it's chemo, it's a gift that keeps on giving. It'll break the cells down and keep the serotonin. You can have serotonin crisis with embolization. How can one? This is a tough one. Is Dr. Metz in the house by that chance yet? Dr. Metz will be talking tomorrow, but I think it's an important one, and Gene can help us. How can one distinguish secretory from structural, which is mechanical loss of an ileocecal valve diarrhea? Are there things that work better for structural? He calls it, or she calls it structural. I call it mechanical. When the ileocecal valve is removed, I don't know. Is Dr. Wang here as well? Maybe he could answer. Imodium cholestyramine is very good. We've used that for that, in fact, and that seems to help the diarrhea. But that kind of diarrhea is tough, and you can try higher doses of octreotide. The difference, I think, is how much fluid loss there is. With secretory diarrhea, you lose bicarb, you lose potassium. There's no question. You get acidotic, your chloride goes high. Looks just like a VIP. It's not as fulminant as VIP, vasoactive intestinal peptide diarrhea, not as fulminant. but it's there, and people require hydration sometimes in between with secretory. But with the loss of valve, I don't know if, Gene, you want to comment on the ileocecal valve loss?
Well, if you have secretory diarrhea, you can pass the patient for 72 hours, the diarrhea goes away. Whereas if you have mechanical diarrhea, where you have the loss of the ileocecal valve, that basically will only be present when the food's there. So you basically have to work through that by, like Odo said, trying biosol, trying polystyrene, doing those kinds of things ought to get rid of the symptom of a loss of a valve. The trouble is that the loss of a valve can last a year, can be a long term.
Yeah. Yeah, I think that's another important point, duration. A lot of times there's an accommodation over time, but it can last a long time in our experience. We'll bring that up again to Dr. Metz too, as he sees it from his gastroenterologic side. Can you be enrolled in the telotristat study?
Go on with that. I just need 1 second.
Okay.
Thanks.
Sorry to interrupt. Before this program ends, I just wanted you to note the feedback surveys that we gave everybody. Please fill them out. They're very, very important to the continuance of these programs. So I don't want to take too much time explaining what they're all about, but please fill them all out.
The one yesterday?
No.
It's on.
Yeah, this is, for a speaker.
I forgot to put that.
You'll give them to Tricia, who'll be over there, or Mary, who'll be on this side. Or if you just drop them on the table in the back, that's fine as well.
They're out in the front, aren't they? This is so painful for a speaker to have to hear this. I was at Cleveland Clinic about 10 years ago, and they had these feedback monitors, okay? And so I barely get off my talk, and all of a sudden you just hear little subtle clicks, and there's your score on the board. I said, holy Jesus. It's like the Russian judge. You have to throw that baby up there. It was awful, awful feeling. It's like the Marriott every time we do this. Okay. Now, can you be enrolled in the telotristat study if you continue to use diarrhea medications such as Imodium or tincture of opium?
I think while in the study, you can use somatostatin analog for sure. I think if you're on Imodium or tincture of opium, you have to be on it first chronically. I don't think you can add it on, but offhand, I would have to double check the study. When you're on the study, they're very specific on the inclusion-exclusion criteria. So again, if you're on it chronically, I think you could, but if you were to add it on during the study, it would confound the results, obviously. So.
Ooh, good. Okay, very good. I think if a patient's tumors are non-functional, why should he or she switch from Sandostatin LAR to lanreotide depot? Why should they? Personally, I don't know if they're on octreotide and they're tolerating it. There is indication that we've had people whose anatomy I think was alluded to in the past is a very thin anatomy, and granulomas are real things, and it's like putting a needle in a knob of a tree after they get the granulomas. And I have switched people with granulomas who've been on it 4 and 5 years of the LAR. I've switched them over to the depot because, as was noted, that's deep sub-Q. That doesn't go into the muscle. And you can use the anterior part of the leg. You can just stick it straight down. The only thing intimidating is the bore of the needle, not the size of the needle. It's 1 inch, but the bore is about I don't know if it's 14 or 16 gauge, but it's a wide bore and it's a little intimidating. But they bring lanreotide has a service, and I think octreotide too, that will the nurses will give shots. And you don't have to go to the physician's office to get the lanreotide depot. That can be given at home. Okay, so, good. Okay, let me sorry, I'm not so fast here. Just get one here as a... other than progression, are there any other reasons why the serotonin level would rise or fall? What about plasma 5-HIAA? Mia can answer, but the correlation, as was shown on that one slide, is very, very tight. So if you have high 5-HIAA levels and a known tumor in your liver, then that correlation with the plasma 5-HIAA will be very, very real. I have seen early on when Prozac was discussed, Dr. Werner answered that question this morning. When Prozac and Zoloft first came out, I must have had probably 10 patients whose 5-HIAA was elevated. And in actual fact, we know that that can raise plasma serotonin levels. And in fact, as Dr. Werner said, you can precipitate crisis with Zoloft. They've reported it with Zoloft, and I think one case of Prozac had carcinoid crisis in a known metastatic carcinoid patient. But the generally good news is that you're on octreotide, so you're really kind of protecting yourself. And for the most part, I think most physicians who deal with neuroendocrine tumors use the, I use the lowest concentration of SSRIs that are available, or I recommend the lowest concentration of SSRI. You okay with that? That's right. Oh, this one's a little tricky. Is it regarding hypertension and headaches? Is it common to have migraine type headaches 5 days after the Sandostatin shot? Can Mia address this as, let's see, with controlling their problem? I can't read that second part. But can you explain why sometimes migraines can occur after octreotide, 5 days after the LAR shot? The only thing I can say is that if you look at the kinetic of LAR, first 24 hours, it shoots very, very high. And in those cases, sometimes it blocks the hormone called glucagon, and it preferentially blocks glucagon over insulin with a high dose, rapid, and that causes insulin to win, and that can drop your blood pressure, that can drop your sugar, and you could have low levels of sugar and have headaches. I've seen that happen. So I usually recommend the 4 Ps: pizza, pasta, potatoes, and pastry, the day that they get the shot for 2 days. Okay, and it works. Okay, good here. This is a tough one, and I don't know, maybe you can all try it. How much does the plasma serotonin vary in any one individual from one day to another, driving the same short period, let's say for 1 or 2 weeks? Serotonin is one of those hormones, and it's an amine in our experience, that really has kind of an absolute level regardless of the lab that's doing it, if it's done correctly. It has a level of about 180 to 200 nanograms per mil. And for the most part, 95% of the people have serotonins under that. You can have bursts of serotonin. Serotonin is very short-lived in the blood. It's less than 65 seconds. And so the higher you are when you release it, the longer it takes to break down. But for the most part, you know, there are episodes of acute stress, embarrassment, what have you, where you will turn, can turn red and flush, and that's probably a burst of serotonin. But the average level, given all things considered in the plasma, is about 180 or 200. A couple of labs have a high level like 495. I think Mayo has a 495, and when they were doing their controls, somebody rolled in with a high level, and they used the outer range point. But the real reality is it's very there. Most of the hormones are really fixed in a range of normal. I would say I don't see plasma levels of serotonin under 400 with symptoms. It takes about 400 plus before you start maybe seeing symptoms in general. Okay. Let's see here what we got here. Why isn't he? Oh, this is a question for Dr. Thomas. Why is serotonin synthesized in preference to niacin in the carcinoid cell. Is that right?
I mean, well, it takes a lot of machinery to actually make that conversion from tryptophan to 5-hydroxytryptophan to tryptamine. And so imagine that carcinoid cell is sort of upregulated all those enzymes to make that conversion. So obviously that doesn't happen for everybody with Neuroendocrine disease. So I have to imagine that just upregulating all those enzymes. I don't know if there's a better answer.
No, I think that, I didn't. Oh, Dr. Berglund. Impact of Sandoz-Afinitor therapy on renal function. Case. Islet cell surgery, 3 to 5 years of treatment with Sandoz/Afinitor. Renal function went from 1 to 1.5 and stayed there. Is there a relation, can you speak to Sandoz and Afinitor in terms of renal function? I'm not.
Yeah, of the two, I guess I think I'd be more concerned about the everolimus.
Yeah.
And I've heard of reports of renal dysfunction, but fortunately it's not incredibly common. I mean, I would say there are other side effects that seem to be much more common with everolimus than renal dysfunction, but I have seen reports of it.
Okay, very good.
I agree, and I've seen a few cases where people started out with borderline elevations of creatinine that got significantly worse with everolimus and then fell after the everolimus was held. So I think there is some potential for nephrotoxicity, and it may be possibly a little bit more if people have underlying kidney dysfunction.
Diabetes. And that same obtains for risk with PRNT. Hypertension is an underlying factor that can do things a little more fast to the renal function. The PRNT story is the Y90 and the reuptake and the resident time of Y90 in the kidney, because that's a natural mechanism to go back into the kidney. And they say predisposing things that can ding the kidney over time when you have Y90 PRNT as hypertension or diabetes. And that seems to obtain for a lot of different therapies. The kidneys are fairly sensitive now when they're a little bit compromised, and so that's one thing. Do the PROMET and clarinet studies represent a before or after surgical intervention or removal of known tumors? Maybe you can help on those. Dr. Fang gave a good result, but I thought that they could be unresectable, stable people in some of the patients.
Right. There was no requirement on either trial that the tumors be resected. There were certainly patients who did have primaries resected. It was a mixed bag.
Yeah, I would agree. I mean, I think the important thing is to keep in mind that there are two basic kinds of studies that have been discussed today, but most of them are treating people with disease that's in place, and the goal is to prevent growth of the disease that's in place. That's different from using treatment on top of surgery, which would be to protect people from developing a recurrence. That's called adjuvant therapy. And we have really no data to guide us there, except for this one trial that's currently enrolling in pancreatic neuroendocrine tumors after liver resection, and that's the trial ECOG 2212, which is everolimus versus placebo after surgery. Again, that's to prevent recurrence. But everything else we've been discussing today is really for people with disease in place and treating symptoms or tumor growth.
Thank you. How about thalidomide therapy? I would take.
Thalidomide has been used in neuroendocrine cancer, and there is some potential for response. It's actually rather toxic and immunosuppressive and has other toxicities, including causing severe and sometimes overwhelming fatigue. So it's not something that has really gone very far in development after just the early trials looking like it has activity. I don't think it's a big player at this point.
I agree.
Yeah, thank you. Survival rates. Are the 10-year survival charts based on the treatments that were known 10 years ago? Are things better now? And speaking to the, narrowing it down to these newer agents that you folks are experts.
I think that's a great question, and it's good to pick up that my couple of comments are, number one, anytime you ever hear somebody present survival data, remember that's an average. And I think that's so important to remember for patients, that just distills lots of different stories and patients and outcomes into one number. So keep that in mind. That's just a ballpark estimate. But I think it's very true for our modern era of treatment, and certainly in the era of pancreatic neuroendocrine tumors, we have very little information about the long-term effects of these treatments.
I agree, and as was pointed out earlier, in centers that specialize in treating neuroendocrine cancers, survivals over 10 years are common, and if you look at national pooled data, where a lot of it is from doctors scattered through the country who don't have the same experience, the survivals are drastically less. I think Dr. Woltering showed some of that data earlier.
And I think sometimes when we're reading some of these stats, we're reading survival of, like you're saying, of change of the cell. It doesn't mean you're going to die in 24 months.
Right. Median progression-free survival has nothing to do with actual survival of patients. It's just something which is a measure of how effective an individual treatment is for a period of time.
And, you know, and one of the things that I think is helpful is when you talk about the incidence, the new cases, the new diagnosed cases in a year, it's about 13,000 cases. But then you say, what's the prevalence of folks, people walking around with neuroendocrine tumors in the United States at one instant? It's about 140 or 150,000. And that tells you immediately about durability and length of life. I think it does. How do you measure a specific receptor response to somatostatin analog treatment, e.g. receptor 1 versus 2? The way the neuro said God nature put neuroendocrine tumors together was 85 to 90%. These are specific exam studies of several different neuroendocrine tumors, possess receptor subtype 2. Now, we all didn't know that. And when octreotide, you talk about the blind squirrel finding the acorn. When octreotide came out, when it was first developed, okay, 21 steps to develop octreotide, 1980, it was declared the first analog or congener. They had no idea. They knew it looked a lot like the ring of native somatostatin. They did not know that it had a higher attraction to the receptor subtype 2. So we know that it's a given that most of these tumors, thankfully, have receptor subtype 2. And in fact, there's new work now that show that grade 3s, these are the bad ones we've heard about, greater than 20% Ki-67, 46% of grade 3 tumors possess SST2. And what that means is if you have it, you ask your docs to do an Octrea scan, because if it's positive, you're in the same treatable ballpark as grade 1 and grade 2 tumors. That's a very, very big finding, okay? And so we know they're SST2s. SST2 happens to be a very important receptor because it internalizes the whole thing. It takes somatostatin and octreotide or lanreotide and brings it inside the cell. So now you have a reservoir, acting reservoir that Gene has shown a long time ago seems to stick inside cells. So octreotide hangs around inside a tumor cell for a long, long time. Please.
So Tom, I think it's worth mentioning at this point that there are different types of people that are called grade 3.
Yes.
It's a heterogeneous group.
Yes.
And the group that have a Ki-67 between 21% and 55% are the ones that are most likely to have SST2 receptor, to have a positive octreotide scan, to have potential benefit from somatostatin analog therapy and PRRT. Then there's a group with a Ki-67 that's greater than 55%. And these are people like small cell carcinoma of the lung, really, really high-grade neuroendocrine tumors, and those usually don't. So I think that we shouldn't just think grade 3 is grade 3. It's actually quite different.
Yes, that's what I was trying to say. But that's exactly right. Thank you.
How long has Ki-67 testing been available?
The first paper, just happen to have that little fun fact. was, I can't remember the author, it was 1986. And what happened, the reason why it was popular was because they were able to immortalize the antibody. That's something you have to remember about pathologists. They're very, very puristic. Unless you can provide a measurable part of the assay, enough to feed the pathologists around the world, you're not allowed, you can't commercially do a test. And so you're really looking at a little piece of a chromosome that talks about proliferation. We saw the stains earlier about the Ki67. That's just the region of the chromosome that the antibody was made. They made an antibody of it, and they were able to immortalize it so that all pathologists in Europe and the United States can use that antibody to measure. So that's a very commonizing, helpful. They've done a lot of correlation with survival with the Ki67, less than 2%, 1, 2 to 22, and greater than 23. So it's a wonderful, and the United States has not been rabbits in terms of getting this in, because Europe has been preaching this for a long, long time, that the Ki67 should be part of the criteria for the classification. And now we're doing it, and NANETS has come along and done it. So, and another name for it is MIB1. That's just another antibody on the chromosome recognizing. MIB-1, you'll see it's the same as the Ki67. And one more question. Can extended treatment with Nexium, powerful proton pump inhibitor, cause NET in the midgut? Not the midgut necessarily, no, it won't. It'll cause and it's a medicine-made neuroendocrine tumor maker. Okay. So if you know the history of PPI, and Dr. Metz is not here, but we can ask him that tomorrow. He goes back with Nexium and the PPIs a long, long time. You go back to the literature, and they used to recommend up to 5 to 6 years of PPI use with impunity. Now look at it, it's 3 months. Okay? That's and then that's true. Now, so then the other point about it is, when you shut acid off more than 75%, you have a hormone in your gut, in your stomach, that reacts. That hormone we saw is called gastrin. And gastrin then goes up because it can't turn acid on because there's no acid. It keeps trying to make more acid. That's its job, but it's shut off by a medicine. Gastrin then goes to the cell that looks like a neuroendocrine cell, and it starts to rise the chromogranin A. And chromogranin A cells are like little tiny cobblestones on the lining of the stomach. And where you see it most is in pernicious anemia, because in there is no acid, and the gastrin levels run 2,000 and 3,000, and we have all seen patients with hundreds of small neuroendocrine tumors of the stomach. And the way you fix it is by shutting off the gastrin. And the way, as Dr. Woldering showed in his paper, the way you fix it is with octreotide. Octreotide will lower gastrin secretion, and it turns off the mechanism for the chromogranin A in the stomach. I have not seen one of those become a malignant tumor, what they call type 3. I've never seen it. I've seen them all stay in the stomach, and I've seen them all eradicated. Usually they're under 10 millimeters in size. And an endoscopic laser kind of guy loves them, because he goes in, and he or she, and they burn them all out. And it's hard to do.
And then don't forget, you can differentiate. If you have a high
Yes.
chromogranin A, ordering the pancreastatin test can tell you if it really is elevated, or is it the PPI causing the elevation? And that's another paper that's on our DVD.
Yeah, yes. Pancreastatin will be normal in this case of PPI users. Chromogranin will be high and gastrin will be high. But pancreastatin almost always is in the normal range. Gene showed that. I think we'll call it a day. Thank you very much.